Good morning, everyone. This is Dave Sella, and I want to thank you all for joining us for Grand Rounds. Today's speaker, who I'm really pleased and delighted to present to you, is Dr. Nan Rothrock. She's a professor in the departments of Medical and Social Sciences, Psychiatry and Behavioral Sciences, and Neurology in the Feinberg School of Medicine here at Northwestern. She serves as director of the Outcomes Measurement and Survey Core at the Robert H. LURIE Comprehensive Cancer Center. Nan's a licensed clinical psychologist and provides psychological evaluation and treatment as part of the supportive oncology program here in the Cancer Center. After receiving her PhD from University of Iowa, she interned at University of Chicago and then did a postdoctoral fellowship in psychosocial oncology at Keller Cancer Center in Evanston, which at the time was affiliated with Northwestern. Her research focuses on the application of patient-reported outcome measures in clinical research and clinical practice. This includes the creation of many and various assessment resources, the development and evaluation of implementation tools, and adaptation of health information technology. The title of her presentation today is Patient-Reported Outcomes in Cancer Research. Please ask questions for Dr. Rothrock in the chat, and we'll get to them at the end of the presentation. CME credit will be listed in the chat. The information will be listed in the chat. So with that, take it away, Nan.
Thanks, Dave. Let me go ahead and share my screen. Well, thanks so much for that introduction, Dave, and for the opportunity to talk today at Grand Rounds. As Dave said, I want to talk a little bit about patient-reported outcomes in cancer research. To start, I have nothing to disclose. My agenda today is to provide a little history, a little background on how patient-reported outcomes have been used in cancer research in recent decades, and then provide some recent examples of clinical trials using patient-reported outcomes. And I want to end by sharing some resources that you can use now to help your own research. So to start, I want to make sure everybody has the same definition. Patient-reported outcomes, according to the FDA, are any report of the status of a patient's health condition that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. And that covers a lot of different concepts. It can include symptoms like pain, fatigue, and anxiety, functional status like physical function, cognitive function, social function. It can also include those concepts found in positive psychology, positive affect, meaning and purpose, life satisfaction. And then I think very confusingly, it can also include concepts that are intermediary or process ideas, so things that aren't outcomes necessarily, but self-efficacy or expectations. And then finally, the big one is health-related quality of life, or HRQL. This is a big umbrella term that includes many of these constructs and is often something that we all agree is important and defined in slightly different ways. So a little history of patient-reported outcome measurement. So I found a study in the 50s that was published that was reporting on the psychosocial impact of head and neck cancer using some non-standardized measures, but it was a recognition, and in cancer, it I think was one of the earliest fields to really recognize that there are impacts of disease and treatment that are really captured by the patient's voice, by asking the patient about how they're thinking and feeling. In the 1960s, that term quality of life started to emerge, and it has been attributed to Eisenhower's Presidential Commission on National Goals. This was a statement in an essay about that. A society which puts a value on the quality of its national life will want to act resolutely. So at that time, this phrase quality of life started to be utilized. Then in the 80s, there really was this explosion of publications, particularly in oncology, that looked at quality of life, often using that phrase, quality of life, as well as fatigue and pain. Then in the 1990s, there began to be a recognition that there were some problems in how we were measuring and evaluating quality of life, including that there were these definitional differences. What is meant by quality of life varies study to study, and there was insufficient information about measures. And I'm showing a couple papers here, including one by Dave Sella himself in 1990, talking about these methodologic problems in how quality of life was being measured and assessed. So then started this push for standardization. In the 90s, there were a number of policy recommendations for how quality of life should be assessed in cancer clinical trials. On the left is a paper by Carolyn Gauthier on recommendations for protocol development. On the right is a paper by Carol Moinpour reporting on resolutions for the Southwest Oncology group, indicating what should be measured, specifically physical function, emotional function, symptoms, and a global quality of life score, as well as social function. People should use measures that are completed by a patient. They should be filled out by a patient, not by interview. And those measures should have documented psychometric properties. As far back as 95, here's another paper recommending what specifically should be measured. This was in the case of head and neck cancer. So this was illuminating, because one of the things you'll see as we get to resources is this is still an issue about what should you measure and how should it be defined. So following this growth in research, the journal Quality of Life was first published, and then in 1994, the International Society for Quality of Life Research was formed and held its inaugural conference. This is really the meeting for patient-reported outcome measurement scientists. Their mission today is described as advancing the scientific study of health-related quality of life and other patient-centered outcomes to identify effective interventions, enhance the quality of healthcare, and promote the health of populations. In 1997, the FDA Modernization Act passed, and here the FDA started increasing their emphasis on what they now called health-related quality of life. So we've gone from quality of life to health-related quality of life, and the FDA recognizing this is an important aspect of label claims. Then in 2009, the guidance for industry was published, and now the term patient-reported outcome measures was utilized, again, highlighting the need for standardization and solid methods for supporting label claims. This has continued and accelerated with the 21st Century Cures Act. This law went into effect December 13th, 2016, and it includes a section on patient-focused drug development. So all new drugs as of June 2017 need to include a statement summarizing patient experience data that was submitted and reviewed as part of the application to the FDA. And here is Barack Obama signing that bill into law. So what is patient experience data? Patient experience data is data collected by any person that includes patients, but also family members, caregivers, patient advocacy organizations, disease research foundations, researchers, and drug manufacturers. That data is intended to provide information about patients' experiences with a disease or a condition, and it can include data regarding the impact of the disease or condition or a related therapy on patients' lives. It can also include patient preferences with respect to treatment of the disease or condition. So in this way, patient-reported outcome measures are becoming more central to how the FDA is evaluating label claims. The FDA has provided two guidance documents thus far. The first is on collecting comprehensive and representative input. And the second was just released in February on methods to identify what is important to patients. 2 more guidance documents are in the works. They include methods to select, develop, or modify fit for purpose clinical outcome assessments and incorporating clinical outcome assessments into endpoints for regulatory decision-making. So again, this move to increased standardization and use of rigorous methods is continuing. So how this will impact patient-focused drug development is something we'll all be watching. This is a study from last year showing that new drug claims that had label claims based on patient-reported outcomes between 2006 and 2015, they were about 20% of all new drug approvals. In a 4-year period, 2016 to 2020, so just at the time the 21st Century Care Act was signed and starts going into law, there was an increase. It's about 26%. And so this will be something we'll be watching to see if this new emphasis will accelerate how frequently there are label claims based on patient-reported outcome measures. One tool that was also introduced in the 21st Century Care Act is aimed to try to make this easier to do. And that is the qualification of drug development tools, or DDTs. So a DDT are methods, materials, or measures that have the potential to facilitate drug development. And qualification is a determination that a DDT and its proposed context of use can be relied upon to have a specific interpretation and application in drug development and regulatory review. So one qualification program is 4 clinical outcome assessments, which are a measurement of a patient's symptoms and overall mental state or the effects of a disease or condition on how the patient functions, and it includes patient-reported outcomes. So the exciting piece about this is that once qualified, DDTs will be publicly available to be used in any drug development program for the qualified context of use. So the idea being, if a measure is, if a patient-reported outcome measure is qualified in a specific condition to measure a specific construct, then another study can use that same measure without needing to demonstrate the same level of development of that measure. That the FDA will take them at their word that this is a measure of fatigue, for example. So what had been a challenging process on getting patient-reported outcome measures in label claims will hopefully be a little easier. So far, there are only 7 qualified patient-reported outcome measures. One of those is in oncology for non-small cell lung cancer, and that is the lung cancer symptom assessment questionnaire. There are a handful of others that are in progress, including PROMIS physical function and measures of disease-related symptoms in different oncology populations. So with all of that said, there's this push towards standardization, push for inclusion of patients' voices in clinical trials. I'd like to shift gears and talk a little bit about some examples of how PROs are being used in cancer clinical trials and what they can add to our knowledge about the experience and treatment of cancer. So to start, I want to highlight the TAILOR-X trial. This was a landmark trial where women with breast cancer were assigned or randomized based on their oncotype score to either endocrine therapy alone or chemotherapy and endocrine therapy. And this created an opportunity to really look at the unique contributions of chemotherapy. There were about 1,000 women that were enrolled, and results on the PRO outcomes are based on 454 women who had complete data at baseline and at 3 months. This graph shows perceived cognitive impairment, or what patients often call chemo brain, a really important symptom that patients experience. The blue line here shows the endocrine alone treatment arm. The red line shows the chemoendocrine arm. And what you'll see is that at 3 months and at 6 months, women in the chemoendocrine arm had more deterioration in their cognitive function. They had more perceived cognitive impairment. By 12 months, the groups were no longer statistically significantly different, and that persisted across 36 months. What you'll also note, though, is that their cognitive impairment stays below baseline for both groups. It did not return to pre-treatment levels, regardless of the treatment women received. So this supports evidence that long-term cognitive impairment, even among women who are receiving endocrine therapy alone, points to the need to better understand this symptom. The Taylor-X trial had other impactful findings as well. This includes, similarly to what we saw with cognitive impairment, fatigue and endocrine symptoms were more severe at 3 and 6 months, during and immediately after chemotherapy, among women who were randomized to the chemotherapy and endocrine therapy arm. Yet they were persistent and comparable between both groups at later time points. Collectively, these findings challenge our assumption that endocrine therapy is well tolerated and point to the need to better understand predictors of early endocrine therapy discontinuation. Another study looked at predictors of that long-term adherence to endocrine therapy and found that it was baseline health-related quality of life, specifically physical well-being, a history of depression, and younger age that were associated with early discontinuation. Another finding from Taylor-X was that social determinants of health, specifically being uninsured or underinsured and living in a neighborhood with higher neighborhood deprivation, were associated with endocrine therapy non-adherence. Another trial, the E205 trial, is a phase 3 trial of sunitinib or sorafenib compared to placebo for patients with renal cell carcinoma. And this is the randomization and stratification figure. The primary quality of life objective was to compare fatigue on targeted therapy to placebo. Here you see on the x-axis is time, on the y-axis is a FACIT fatigue score. The blue and orange lines are the 2 trial conditions, intervention arms, and the green line is placebo. And what you see is that fatigue worsened on all arms after 2 cycles and remained stable at 22 weeks. When fatigue was assessed with CTCAE grade, patients who had a grade of 0, no fatigue, when you looked at their self-reported fatigue, their FACIT fatigue, 25% of those patients reported on the PRO significant fatigue. So this supports our understanding that patient report can vary from clinician report, which of course, we knew, and that patient-reported outcome measures provide unique information. This also supports using PROs to really understand the tolerability of therapy, specific therapies. The E1Z03 trial is a great example of a trial with negative yet impactful health-related quality of life findings. This trial compared 2 aromatase inhibitors among postmenopausal women with breast cancer. The companion trial looked at endocrine symptoms and health-related quality of life as well. So what you can see, even without doing any statistics, is the 2 arms were equivalent in endocrine symptom scores. And that was consistent across time from baseline through 24-month follow-up. So at the time, there was concern that, well, so I should back up and say, so one of the things this highlights is in making treatment decisions, it is helpful to know there's no difference between these 2 agents in fatigue and, in endocrine symptoms. So at the time, there was growing interest in discontinuation of aromatase inhibitors. And this graph shows in, the 2 intervention arms are shown in the red and blue line, and they're equivalent. We're looking at over time, how many women discontinue using an aromatase inhibitor, and they're highly similar or the same. So then the data was looked at based upon this item, this PRO item, I am bothered by side effects of treatment. So women were grouped where women who reported not at all or a little at baseline are grouped together and shown in this red line. Women who reported somewhat, quite a bit, or very much are grouped together and are in this blue line. And what you see is that women who reported being bothered by side effect treatments at the initiation of an aromatase inhibitor were more likely to discontinue its use early. It appears that this is demonstrating that women at the baseline time point of a trial, it's not necessarily their baseline. These women were more likely to have had prior chemotherapy, radiation therapy, and on medication for comorbid conditions. And so their threshold for tolerability was different than women who were entering the study without that history. Ethan Bosch has published 2 studies looking at routine symptom monitoring in individuals with undergoing cancer treatment. And his study had weekly reports of the severity of a number of symptoms, including appetite loss, constipation, cough, diarrhea, dyspnea, dysuria, fatigue, hot flashes, nausea, pain, neuropathy, and vomiting. His studies showed that participants who were in the arm where they were completing these measures every week, they reported better quality of life, as shown here. The usual care arm patients are clustered by if they had worsened quality of life, unchanged quality of life, or improved quality of life. In the intervention arm, a larger number of folks reported improvements in quality of life. When that same data was reviewed looking at change that would be at a level important to patients, the findings held, though with slightly lower percentages of individuals showing improved quality of life. Patients who participated in this weekly symptom monitoring also had fewer emergency department visits. And of course, the big finding was that 2-year survival, and this was with 121 lung cancer patients. These individuals had a survival benefit. So in summary of these highlights of recent clinical trials, we see that we can quantify the impact of treatment on important domains of health. We can use PROS to clarify the timeline for that impact. When does it start? How long does it persist? When does it resolve? We can identify predictors of early discontinuation or non-adherence, and we can provide information that's not captured by provider report, among other benefits of PRO use. So now I want to switch gears and talk about some resources that really build on this history of recognizing that selecting, collecting, analyzing, and interpreting patient-reported outcomes requires the application of rigorous methods, and that it often benefits from utilization of expert guidance. So there are a number of resources that are available today for free. The first I want to highlight is the Proteus Consortium, the patient-reported outcomes tools engaging users and stakeholders. The aim of this consortium is to promote systematic use of methodologic tools developed to optimize the design, analysis, reporting, and interpretation of PROS in clinical trials. This started as a PCORI award and now is supported by some Genentech funding. The consortium includes patient, clinician, research, and regulatory groups, both here in the United States and internationally. The tools and resources cover writing PRO protocols, selecting measures, analyzing data, reporting findings, graphically displaying findings, and interpreting PRO papers. And the resources are in checklists, as well as in introductory and advanced videos. So depending on your preferred learning style, you can read something or watch something. They've just published their handbook, and they also point to a number of good references. Here are some examples of the checklists that are available through Proteus. This is a protocol guidance checklist. So those calls way back in the 90s for improvements in protocols has continued and is more sophisticated and detailed in checklists like the ones we have today. We have a checklist for evaluating studies with PROS. So if you're reviewing an article for a submitted article for a journal, this is a great tool. There's a checklist for displaying PRO research results back to patients as well, which is really helpful, I think, not only to patients, but to providers and other collaborators. Here are a couple of papers that they highlight. Recommendations for including or reviewing patient-reported outcome endpoints in grant applications is a really helpful and useful tool that you can apply now. JAMA publication on guidelines for inclusion of PROS in clinical trial protocols is also available, and is also available as this is the introductory video. ECOG Akron also has a number of resources for its members. There's a PRO working group that provides consultation and feedback on PRO designs and measures for ECOG Akron studies, support for obtaining measures, licenses, and translations. And this says coming soon, but I believe it is available now, this PRO reference library that includes links to the Proteus tools and resources, as well as details and access to measures, boilerplate descriptions of measures and citations to include in protocols, a list of available translations, guidance on manuscript development, and other helpful resources. Here at the LURIE Comprehensive Cancer Center, there are a number of shared resources, which we all know of, that are providing services, equipment, and expertise to help facilitate your own research. One of those is the Outcomes Measurement and Survey Core. The mission of the OMSC is to provide consultation and support for research that involves collecting, analyzing, and interpreting self-report data. We provide, another part of the mission is to help identify the best ways to measure outcomes derived by self-report, to serve as a central resource for state-of-the-science instruments and measurement methods, and to provide in-house support services for translation, collection, and analysis of outcomes and survey data. The OMSC faculty includes myself and Dave Sella, as well as Karen Kaiser, who is an expert in qualitative research, Jinshe Lai, who is a psychometrician, and our coordinator, Sarah Buono, who works both with the OMSC and with the ECOG Akron PRO working group. We also are able to draw upon a number of other faculty and staff, including study coordinators, bilingual interviewers, translation specialists, data entry specialists, psychometricians, and statisticians. So depending on a user's needs, we can help connect that person with someone who has the right expertise. We have 4 areas of expertise. The first is in survey methodology. We can help with question wording, formatting, sampling, timing, respondent and staff burden, methods of assessment, and helping to train interviewers. The second area of expertise is in qualitative research, including conducting focus groups, cognitive interviews, linguistic translation, and adaptation of existing measures. We have expertise in patient-reported outcomes, including the selection and development of measures, symptom burden, health-related quality of life, and treatment satisfaction. And finally, we have expertise in psychometrics, including reliability, validity, dimensionality, item response theory, scoring algorithms, measurement bias, sensitivity to change. The final resource I want to highlight is the healthmeasures.net website. This is the website that is the primary dissemination point for PROMIS, the patient-reported outcome measurement information system measures. These are the measures that are integrated in the Cancer Center now, assessing physical function, fatigue, pain interference, anxiety, and depressive symptoms. On this site, you can download respondent-ready versions of hundreds, we might be over 1,000 now, measures from PROMIS and from other large measurement systems supported by the NIH. And there's a lot of guidance, so similar to this theme of these resources through a number of avenues, providing guidance on measure selection as well as implementation. I focused on clinical research, but there's a lot of information as well about implementation in clinical practice. There's guidance on scoring, as well as interpreting those scores. And then lots of basic information about measurement science. So if you want to learn more about item response theory or computer adaptive testing or performance measures, you can find some helpful information on the healthmeasures.net site. So I want to conclude there and allow some time for questions and discussion. I want to first start by acknowledging the OMSC team, as well as Devin Pipert and Lynn Wagner, who helped share some of their slides for my presentation today. I want to thank you for your time. If you are interested in learning more about the OMSC or utilizing our consultation services, you can contact us at omsc@northwestern.edu. So I will stop sharing there and open this for questions.
Thank you, Nan. That was really a fantastic overview of the history of patient-reported outcomes in oncology, and the examples were great, particularly for an ECOG-oriented audience. Many of the people at the talk here are familiar with ECOG and participating in ECOG. And closing with resources was really very helpful. This grand rounds was actually initially conceived out of an awareness that there is not enough realization of all that's available to you in the audience and your colleagues in terms of doing good quality of life science or patient-reported outcome science. And your best one-stop shop for that would be the OMSC, and that consultation, like as with biostatistics, is not charged to you. It's covered by the Cancer Center core grants. So give Nan a call, and the right person will be directed to you to help guide you with where you're going or want to go. There is one question that came up in the chat, Nan, which I'd like to direct to you. It comes from Derek Wainwright. I'll just read it, Derek, but you may want to unmute and chime in. What are the outcomes called reported by family members rather than the patient when the patient's incapacitated or cannot accurately report their status? He's thinking of a patient that might be confused or have dementia or other cognitive impairment.
Mm-hmm. Yeah, that's a great question. So we often call those proxy reports, and can be incredibly helpful information in those cases, like when someone is cognitively impaired and not able to report for themselves. It's also an issue in assessment with pediatrics. There are concepts that are really helpful to ask parents or caregivers about that patients can't report on for themselves. There's some methodologic issues with that, of course, that another person's report is not the same as an individual's report, but I think it's better than nothing. And so I think they can be incredibly useful to collect. And then when it comes to analysis, there needs to be some attention on who is the person that is responding and providing this information, and to not equate a proxy response with a self-report.
Yeah, there's another term. So proxy is the more familiar and commonly used term, but the FDA introduced another term that kind of runs parallel to PRO, and that's OBSRO, for observer reported outcomes. And that can be a family member, can be a clinician, any observer who has some degree of knowledge of a person's status can provide that report. Sarah Fenton's asking, Nan, thanks for the great talk. In your opinion, what role can PROs play in small, early phase trials where dosing is being established? Or are other measures in development are useful for incorporating PROs in trials with small patient groups?
So what is the role PROs can play? I think PROs can play a role in helping identify important symptoms in those dosing studies. I'm not sure more about what you're asking specifically related to earlier trials.
Maybe if I unmute, it's a hard question to ask. Sorry for interrupting you. Really, I'm just thinking about incorporating those questions in those trials where, you know, each dosing group is maybe only 3 patients. Do you find that PROs are useful in finding not like side effects that we wouldn't have noticed otherwise? Or are there other tools that you would recommend so that we can incorporate patients' opinions and not just the physician's opinions of the toxicities patients are seeing?
Yeah, I think absolutely PROs are useful, and the PRO CTCAE offers single symptoms, single item assessment for various symptoms. I think my general perspective is it's better to get information from patients, even if it's messy, than to not get it. Certainly the small sample sizes do make it difficult to look at specific comparisons between dosage, but it certainly would be preliminary information to help identify what symptoms are emerging or important. There also, I think, is a place for qualitative work in interviewing with patients and collecting from them more about their experience and what symptoms or issues are important. Dave, would you add anything?
I think you provided a great answer. I guess one thing I would add is that the FACET also has an item library, and I think scanning for side effects is really the main use. Bettina Yanez, working with Jeff Sossman in the translational, the Olson Pavilion Clinic, along those lines. You can use PRO CTCE and select symptoms. You can use the FACET library and select symptoms. You can also, if you want to get really sort of basic about it, ask the one question that Nan showed on that slide from the aromatase inhibitor trial. I am bothered by side effects of treatment, just to get a read on how many people are quite a bit or very bothered, kind of a patient-reported grade 3-4 toxicity, if you will. Mary Mulcahy asked Nan, any known consistent difference in those who complete PROs and those who do not?
Well, a real obvious one is language. Quite often the measures themselves are collected only in English, and so that excludes individuals who are not, don't have a level of literacy to complete a measure in English. Otherwise, so consistency across studies is harder to do, because I think a lot of it depends on, if we're talking about within clinical research, quite often there are so many mechanisms to facilitate more complete data collection. When PROs are collected in clinical practice, we certainly see patterns in individuals who are less likely to complete PROs, including sociodemographic factors, issues about relationship with the provider organization. Again, that proxy or OBS versus self-report. But in trials, I'm not aware of real consistent differences.
Yeah, in clinical trials, hands down, the biggest reason for non-response is unfortunately on the site. People forget. They don't remember to ask the patient. So it's not patient-based difference. It's more of a site-based difference. The other one is, of course, coming off the experimental therapy. Even if the protocol calls for assessing quality of life after the treatment is stopped, either for progression or toxicity, that's a big trigger for risking more missing data. And that is more patient-oriented, because those patients tend to be sicker, so you get a bias introduced when that happens. Other than that, patients on clinical trials, 95% of them will do it without objection. In clinical practice, as Nan said, there is an education effect that's pretty consistent. Less educated patients are less likely to complete the clinic-based questionnaires. Lila Garzai asked one interesting interplay between PROs and outcomes that I'm not sure we completely understand is the potential for the very measurement of PROs and potential interventions that might follow from clinicians to influence outcomes, specifically in oncology trials. How can we disentangle that effect to make sure that we understand how trial outcomes may translate in the real world where PROs may not routinely be collected?
Well, I think that's an interesting question. There has long been a concern that collecting PROs, just the act of doing that, will impact the outcomes of care. Back in the 50s, there was some concern that just asking people about difficult things like pain or depression would incite pain or depression or make people more aware of it. And that has not been supported. I'm not sure, but in a clinical trial, I think one question is the extent to which the pro data in clinical trials is actually available to a providing clinician at the point of care, and that information is actionable, that information, I think one of the challenges now is when we have pro information, how does that align with clinical actions that should correspond with specific scores for specific measures at specific points in time. So I think that's really where the research needs to go now of, if we do see PRO capture in trials influencing care, when and how, and is that helpful? Does that make an impact on the patient?
Yeah, if I may just amplify, I agree completely, Nan. Lila, the recommendation in clinical trials is not to feed information back to the clinician and patient. It's gathered as outcome data for that reason. But as Nan said, in clinical practice, if all you do is ask questions and then give that information to the clinical team and to the patient, they generally don't know what to do with it, and so it doesn't really change much. That's why the Bosch study and others find that the key to successful actual impact on patient function, quality of life, and even survival is to have a plan of what to do when you see, when triggered problems. And that's indeed what we're doing here at Northwestern as well. So in order to really influence outcome for the patient, you do need to do something about it. But in clinical trials, the questions are asked as an outcome itself, not as a trigger for intervention, if that makes sense.
I would add too, I think the Bosch study, the specific concepts that they were measuring in that study are ones that oncologists can intervene and do something about, and are often those symptoms that are indicative of kind of harbingers of greater problems to come. And so I think, a measure of diarrhea is easier to intervene on than a measure of social functioning. And so I think that's also partly why that trial was so successful, is that link between the measure and a clinical action was much clearer.
Sharif Badawi, also complimenting you on your talk, Nan, asked if you can comment on the utility of using measure-specific MID or MCID as outcomes to demonstrate efficacy for therapies in cancer and other chronic conditions, even when there's no statistically significant difference for domains across groups.
So 2 groups, not statistically significant, but both groups are experiencing a change that is at a level that's important to patients. Is that the scenario?
Yeah, I mean, I will just unmute. Sure. So thanks, Dave, and thanks, Nan. Yeah, I think that's what I was kind of referring to, is you might have differences between the 2 groups, right? The intervention group have some improvement in their PRO scores based on the MID or MCID, but that difference is not statistically significant for different reasons. I think some people are hang on the idea that it's not statistically significant, but we know that this can be clinically meaningful. And I think that's specifically what I was asking about.
Mm-hmm. Yeah, I think oftentimes I see a responder analysis in those cases. So looking at, there may not be statistically significant differences between groups, but there are individuals who do experience an important change in a symptom, which I agree has utility in understanding the impact and how that impact varies across patients. I think there's a lot of really exciting debate about MIDs and MCIDs and what terminology and how to exactly determine that number or range of numbers. And are you looking at individual patients or groups of patients? So there's a lot of methodology work, I think, happening now to try to better understand that and to have some consensus in the research community which is not there yet, certainly for individual patient evaluation. But yes, absolutely, I would say there's utility in looking at those important changes.
Derek's come back with another question. Are there any major published studies that stand out in your mind that whereby PROs or proxy rows or OBS rows have been collected across a large swath of age groups? Example, less than 65 versus older than 65. In patients with cancer, that the pros or proxy ROs provided a strong stratification of outcomes between age groups.
Between age groups. I don't know of a major published study. Dave, do you know that stratifies by age?
Well, if the question is, are there big age differences in these outcomes? The answer is no, actually. I mean, yes, people as they get older, whether or not they have cancer, do have more physical and functional problems. But and mood slightly elevates actually as people get older. Those are not different in cancer versus the general population. But Derek, I'm not sure if that's what you're asking.
Yeah, so sorry, my camera's off. I've been in Zoom meetings all morning. So with glioblastoma, I understand that it's a brain cancer, so it might be an outlier with respect to the type of cancers that you normally study, but we see a large amount of confusion in those patients who are older than 65, and there's a molecular basis for that. The tumor in the brain actually induces a lot of dementia-like symptoms in the older adult brain that doesn't happen in the young adult brain. And we think that the mechanism is related to, Alzheimer's disease and stroke-like symptoms and so on and so forth. So my question is very targeted toward patients with glioblastoma, and whether or not, any other studies out there have ever found any age-related stratification. And, I don't know if the observed PROs or the PROs that are being asked really address the age-related question. I mean, if you put in a PRO for observers to say, do you see more confusion in these patients with or without a platinum-based chemotherapy, or in our case, temozolomide? Has that ever been addressed, or, is that an unaddressed question? Because the observation that our patients are more confused at greater than or equal to 65 years of age is unquestionable. We're about to publish that. But the question now is there a PRO that we can implement in our patient population that helps us to further stratify this?
Nan, you want to take a stab?
You can do it, Dave.
Derek, it's very challenging. Well, of course, what came to my mind as you were introducing your question, although it's not where I would land in the end, was breast cancer, of course, where you do have the age stratification of pre and postmenopausal, and that affects symptoms. And then you can have the sort of postmenopausal symptoms in induced menopause with the premenopausal patient. So you do get that kind of age interacting with cancer in breast cancer, certainly. I can't think of other cases where you do get what you're describing, something like what you're describing. But what I'm wondering about is perhaps working with, PROMIS has these item banks, and there are item banks in cognitive function. It would be very interesting to work with you or to see you work on identifying perhaps specific types of cognitive function that are more sensitive to this sort of interaction between age and the pathology and the molecular level activity that's going on in the older patients, because those questions would then perform differently in the younger versus older patients, and it would help to refine measurement of cognitive function across your glioblastoma patients. That's not sort of biased, if you will, one way or the other toward the younger or the older. Does that resonate with what you're trying to accomplish?
Yeah, that would be great. That would be great. And I don't want to dominate the rest of the question session, so we can talk about.
Yeah, I'm happy to talk with you, as I'm sure Nan would be, but what you could do is start with looking at health measures and pull down those questions in the cognitive, promised cognitive function item bank. There's also a whole set of facet cognition questions as well, because you may see ones that that you think are particularly vulnerable, if you will, or sensitive to the age-related difference in manifestation of the tumor.
Yeah, Derek, I can send you some of those measures and some information about them too, to start.
Sounds great. Thank you so much.
So I don't see any other questions, and we are getting close to the top of the hour. If anyone has any last question, you can unmute. Okay, well, again, Nan, great talk. Obviously, it went over very well. There's lots of interest, lots of questions. I think you'll be hearing from several people and about questions they have in follow-up. So thank you very, very much for this excellent Grand Rounds. Bye, everyone.
Thanks so much. Bye, everyone.